would help if I turn my mic on. Morning, everyone. Welcome back. Monday morning, 10 o'clock. Hope everyone had a good weekend. We are carrying on with the foot. So we're going to carry on a little bit of a recap from where we left off last week. And then we're going to introduce the connective tissue all around the foot and ankle. So basically all the ligaments and the joint capsule. So you can have a look at them and see where things go from and to. But we're also going to do a little bit of an introduction into what a ligament is and what it does. So that when if you're assessing them, if that's the kind of thing you do. Morning, so we've got Julie and Catherine. Morning. Good to see you guys. Welcome. I haven't seen Catherine for ages, actually. Morning. How's your hand? I hope it's. I saw a little video of you with your hand the other day. Hope it's feeling a bit better. Good morning. We've got a few coming in. Good, cool. So let's just do a little bit of a intro here. Let's just go back a few. So we're going to do a bit of an introduction into ligaments first, and what they actually are. Morning, Stevie. Morning. We've got a few more regulars in. I'll do. And Dan's here as well. Morning, Dan, and Al as well. God, we've got all the royalty in this morning. That's good. Okay, taking a bit of a break from massage this week. No problem. So if you lived any closer, then we would help you out. You have to have a chat with Chris Kitson. Because I think he's up near you, Catherine. I'm sure he wouldn't mind helping you out with your wrist, I'm sure. So this section applies to every ligament in the body, and there are basically different types of connective tissue, and they have different properties depending on where they are. So when we have when the ligaments in the body connect from a bone to a bone, and they help to prevent excessive movements in certain directions, but also to help stabilize joints so that they move as they should. They move congruently, and there are certain ligaments that have a bit more elastin in, so they're a little bit more pliable, and some that have less elastin and more collagen in, so they're a bit tougher and a bit stronger. So it depends on where they are in the body. So we're going to have a look at those now. So this is a classic kind of microscopic view of a ligament and what it is. I'm just going to grab my arrow. There we go. So what you can see, that there may be some new names here if you've not done this kind of stuff before. So we've got collagen fibers. Collagen is the main makeup of a ligament. It's a really, really tough connective tissue. And we've got here something called a fibroblast. And a fibroblast is a collagen producing cell. So any cell that has got blast on the end of it, so osteoblast and myoblast, and then fibroblast, they're all building cells. So if you remember blast and build, that's what they do. So a fibroblast cell will basically shoot out strands of collagen depending on the direction that there is stress. So when you if you have an injury to a region, and you don't do anything, you just sit down and relax and put your feet up on the sofa like we used to do years ago, then because there's no stress going through that joint, the fibroblast cells aren't stimulated, and what they do is they end up laying down their collagen, the collagen matrix, in a haphazard kind of crisscross mesh. So it's a bit like a spider web. Okay, so it's a bit kind of all over the place. Whereas if you stress the tissue in the early stages of an injury, obviously not so much that you re-injure it, but you gradually apply load to the tissue, then the fibroblast cells react to that and they shoot collagen fibers in the direction of the forces. So you are much more likely to get these linear patterns of collagen if you rehab areas of your body correctly. This is what a typical ligament would look like. It's a kind of wavy pattern. So there's got what we call a bit of a crimp. So it's like the pleats on in a curtain. So if you pull your curtains together, pull the curtains apart, and then they're all at the ends of the window, then you've got that they're all crimped up. Yeah, and then when you pull them to close the curtains, then the curtains go straight, and that's similar to or similar kind of thinking to a ligament. So there's a little bit of give in a ligament, not too much, but there is a little bit of elasticity and a little bit of crimp, we call it. Okay, so I'm going to show you that in a second. So that's basically a ligament structure, and it's similar to tendon structures, but there'll be different compositions. And it will be similar to the scar tissue formation that you would get if you injured a muscle as well. Okay, so that would be a similar kind of structure. So it is strong along the axis of its fibers. So in a linear direction, a ligament is strong to a certain point. If it's twisted or if it's sheared, okay, so there's a bone here and a bone here, and then there's a ligament across the two. If they're sheared across each other in that direction, ligaments don't tend to like that, and you're more likely to get an injury in that particular movement. Okay, so they're very strong linearly, but not so much in most other directions. So the mechanism of injury is really important as well, because it depends on which way they fell and how they landed, if it was twisted or whatever. So a lot of people, though, when they do injure things, they can't really remember how it happened. So sometimes it's useful. Sometimes someone's filmed it, which is great because you can see it. But quite often people are just like, I don't really know what happened. Okay, so if you've got the information, that's great, but sometimes you don't have it. So this is the stress strain curve of a ligament. So this is the crimp bit that I was talking about here. So when there is little strain on the ligament, so it's basically at rest and kind of in a neutral position, then there is a bit of give in the length of the ligament. Okay, so and we call that the toe region. And when you start to stretch a ligament, so you stretch a joint, that slack, that crimp is then taken up, and then it's straight. So like I was saying about the curtains being drawn, now they're straight. Now if you continue to stress that ligament once it's straight and it's used up all of that crimp, then there's nothing left. So you get a deformation then of the tissue. So here we've got this yield point, so this point here. So you take it beyond that point and you'll start to get little micro tears within the ligament, and you'll get a partial injury here. Okay. The problem with that is that once you've injured it, ligaments have a really big role in the sense of where your body is. So what happens then is the messages coming through to your brain and your nervous system from your ligaments about where your joints are is all disrupted. So then if you've gone over on your ankle and you're in the early stages of it recovering, so there'll be a bit of swelling, maybe a bit of an injury like on the picture here, there'll be a bit of an altered joint sense, so that your brain doesn't really know where your ankle is. You're much more likely to injure it again immediately after that particular injury. So that's why we want to protect the ankle in those early stages to make sure that we don't cause any more problems. And that's why a lot of the rehab work we do as well in those early stages is to do with proprioception, so joint awareness and where your foot is, where your ankle is, so that we can reprogram those networks to make sure that your foot is wired back into your brain again. Okay, so that's the intention there. But if you continue to go, and sometimes this happens when you roll your ankle, you'll get to a failure point and then the ligament will be completely injured. Okay, so if you get to the end of the elastic region here, you can recoil. Okay, so the ligament it has the ability to recoil. As soon as you go into this plastic region, it no longer recoils, and there will be a permanent deformation to that particular ligament. Okay, obviously if it goes to this point, then it's completely ruptured. All right, so and then you've got a complete lack of joint stability. So as we go through and look at the ligaments today, you can imagine what will happen if some of these ligaments get injured, like on this diagram. So let's just have a look at this as well. So if I just move me over there. So this is one of the main roles of ligaments. So they have what's called a proprioception role, which is knowing where your body is in space. So this is the reason why in the early hours of the morning, when you've got to get up at 5 a.m. and it's pitch black, you have got a pile of your clothes on the floor and you're able to still get changed because you don't need your eyes. You know where everything is. Okay, you know where your body is. You know where to put your foot. You know where to put your hands. All of that is proprioception awareness, body awareness of your body in space. So what we've got in ligaments are these little receptors called mechanoreceptors. So they're mechanical receptors which give us feedback into the brain to tell us what is going on in the ligaments. And there are 4 different types. Don't need to know those in any great detail unless you want to. But the main thing that we're looking at, morning Noel. Let me just pop your message up here. Well, I hope maybe some of the information will get across into your little one and they'll end up being an anatomist. You never know. That's really nice. Cool. So one of the main things that we need to look at on this whole slide, because there's a lot of information. So we've got multi-modal sensory system. So these are all the different senses. So the hearing, the sight, the smell and all that. But we've also got this 6th sense, which are the receptors in our body. So we've got receptors in the muscles, in the skin, in the joints, in the ligaments, in the tendons. They're absolutely everywhere and they're feeding back to our brain all the time to let us know where we are. So, and this is really important because if you go over on your ankle, if you roll your ankle, then there are some muscles that follow the line of some of the ligaments. So when that ligament is stretched, then the skin will sense it and the ligament will sense it. So it will send a message to your brain to contract the muscles on the outside of your leg to stop you rolling your ankle. Okay, so and you'll notice this when if you're doing any one-footed balance work, your foot will be like this all the time. Well, it depends on how good your balance is. If you've injured your ankle, then it will take a lot longer for your muscles to react. Okay, but if you haven't injured it, then you'll get this tick, 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 where the ligaments are getting stretched, muscles contract, ligaments stretch, muscles contract, and they're just trying to balance out all the time. And this is happening all the time, even with you sitting there on a chair or with a baby wriggling on your lap. Your body is trying to maintain your body position for you by using the feedback from the sensors in your body. Okay, so this is what we lose when you injure your ligaments. So proprioception is about position and movement, and it's about joint position sense, so knowing where your joints are, the movements that you're doing. So this is something that goes as well with people who have ligament injuries, so they don't know where their limbs are. So if you have injured your shoulder and you get someone to close their eyes and then point to a spot on the wall, they won't be where they think they are because their joint position sense will be altered. Okay, but that is something you can train, and that's something that you can rehab. Sense of force. Okay, so the effort you have to put into something is altered when you lose that proprioception. So you may not put in as much force, or you may put in too much. Okay, so again, that's something you would need to rehab if you have an injury. And then the sense of change of velocity, so the sense of change of speed. Okay, so you lose that as well if you injure this proprioception. So injuries to ligaments can affect all of that stuff. Okay, so that's why these are really important to know, important to understand, and especially if you have to rehabilitate someone after an ankle injury in this example, then this kind of information will be really useful. So a little bit of a recap of terminology if you've not heard it before. So we've got a couple of things. We've got the top of the foot, is called the dorsum. Okay, so the dorsal surface of the foot. Just grab my skelly. So that bit there. So all on the top part of your foot, that's your dorsum, and then underneath, that's your plantar surface or plantar aspect. Okay, so hopefully those bits you remember from last week. This is the fibula. So we know this is the outside of the ankle. So this is lateral. So this is the lateral malleolus. And then this is on the medial side. This is part of the tibia. So this is the medial malleolus just here. Okay, so we've got plantar surface, dorsum, medial, lateral. Okay, so that just a quick recap because that will help us when we look at the ligaments as well. And then on the right hand side here, we've got anything that's towards the body, so towards the midline is proximal, and anything furthest away is distal. Okay, so if we use the example of the tibia, so this is the distal part of the tibia, and then this is the proximal part of the tibia just here. Okay, so proximal closest to the body, distal furthest distance. Okay, so further away. Good. Right, let's have a look at some of these then. So we did have a look at some of these last week when we were looking at a joint called the talocrural joint. So it's the joint where that happens, okay, where you get dorsiflexion and plantarflexion. So that comes from this joint in here, which is the joint between the talus and the tibia. And if you've no idea what those are, we covered them last week. So have a look at them on the video last week. We did an in-depth video on that one. So this is a view of the outside of the ankle, okay, so a lateral view. So therefore, this bone here has to be the fibula. And then we've got these ligaments here. So we've got something called the PTFL, and we did have a look at this briefly last time. So it's the posterior talofibular ligament because it goes from the talus bone, which is the bone underneath the tibia, onto the fibula. Okay, so that outside ankle bone. Then we've got one here, which is the calcaneofibular ligament, or CFL. And this is the thing with these, they've got really long names, but if you break them down, then it's easy. So calcaneo is the calcaneus, so the heel bone. And then fibula is your fibula. So it's that one there. Okay, so that's the CFL. And then this one is the ATFL. So it's the anterior, because it's at the front. Talo, because it's on the talus, fibula on the fibular ligament. Okay, so what we were just saying about ligaments and what they do, you can see that these have got very clear lines of fiber direction. Okay, so if the so what the job of these ligaments is to stabilize the ankle on the outside. So if you roll the ankle, so if, I don't know whether this one will move. No, it's pretty jam tight. But if you roll the ankle and open up that outside of the ankle like you've tripped on the curb and then it's gone over, these are the ligaments that you will injure. Okay, so and let me just got a question there from Stevie. So when I have my spiral fracture, will the ligaments have sheared as well as the bone breaking? Depends. It might have done. Yeah. Depends on how high it was. Depends on where it is. But yeah, it could do. And to be honest with you, you're better off breaking a bone than you are injuring a ligament. Bones will heal in about, obviously spiral fractures aren't nice, but bones will tend to heal in about 12 weeks. But they don't serve any kind of proprioceptive function. But if you injure the ligament, it depends on how severe you injure it. But because of the lack of blood supply, they take a really long time to heal, and you will also lose function in that joint as well. Okay, so again, depends on what you do, but sometimes they leave them, and you can just cope without the ligaments. But if you're playing sports and you're quite young, then usually you'll have an operation to repair it. So it's it depends on what or if you need it for your job. They'll repair them. So let's have a look at the ATFL. So let's go this one. Okay, so this is a similar video to what we saw last week. So this is your ankle joint. So there's your talus bone. These are the medial ligaments. We haven't looked at these yet. They're called the deltoid ligaments. And then that one there is your ATFL. And then got a little bit of movement of the ankle there. And then right at the back, this one here, you've got the PTFL. Okay, so you can see it's attaching to the fibula, and then there's the talus rotating, which is that dorsiflexion, plantarflexion movement. Okay, so that's where it comes from. So that's your PTFL, and that's your ATFL, so the anterior talofibular ligament just there. And then we will have a look at these in a second, but in a bit more detail. So that's the deltoid ligament, which is a series of 4 ligaments. So we'll look at those in a bit more detail in a sec. And that's on the inside of your ankle. Okay, so at the moment we're interested in the ones on the outside. Well, let's just get rid of that. Okay, so these are the movements that are prevented. Let me just go back a bit. So when the ATFL and the PTFL are intact, they stop these movements. So they stop the shearing movement coming backwards and forwards and the rocking movement from side to side. Okay, so those are the movements that it prevents. But that is basically what these do. Okay, so all of these structures in here will stop your ankle wibbling from side to side and then sliding backwards and forwards. And if you've done any kind of clinical testing before, those are the clinical tests that we do to check the integrity of those ligaments. So we would do something called a talar tilt test, where you hold the calcaneus and then you basically pull it across to see whether the ligaments gap. Okay, so you're trying to open up that ankle joint and it should be solid. Okay, so if you remember that graph, there'll be a little bit of give. Okay, so a little bit of elasticity, and then it'll go dunk, and then it won't be able to go any further. And that is a ligamentous end feel. Okay, so there'll be a little bit of play and then nothing, and that's how it should feel. If when you pull it, it keeps going, you know you've got a problem. Okay, and that's the same with the sliding one as well. So what you would do with the sliding one is put your hand here. I'm just going to move you a sec, Stevie. You put your hand here on the tibia, okay, on there to block the tibia, and then you would push upwards on the calcaneus or downwards on the talus to try and slide and shear that joint backwards and forwards. And if there is a problem, it will glide. Okay, it shouldn't move. It should be solid. So that's what those ligaments do. Cool. Let's have a look at the deltoid ligaments a second. So these are the ligaments on the inside of the ankle, and I'll show you another video to kind of wrap up those ones. So we've just seen a little bit of these. So all 4 ligaments together are called the deltoid ligaments. This is on the inside ankle bone. So this is a right ankle medial view, so on the inside of the body. So that bone there has to be the tibia, okay, because the bone on the outside is the fibula. There's your calcaneus, there's your navicular, talus is underneath there. Okay, so the 4 ligaments are posterior tibio-talar ligament, so one at the back that attaches your tibia to your talus. Okay, tibio-calcaneal ligament attaches your tibia to your calcaneus. Tibio-navicular, so from the tibia to the navicular, easy when you know how, huh? And then anterior tibio-talar, so going from the tibia onto the talus. Now, when you're assessing these, there is no way, and when you're poking and prodding around the ankle, there's no way that you'd be able to tell, oh yeah, it's that one that's injured. You wouldn't have a clue, because when you'll see them in a second, they're all just one big mesh of ligament. Okay, so if there's an injury here, you would do the same thing again. It's a talar tilt, but you would open up the inside of the ankle, and again, there should be a little bit of give, and then nothing, and then it's solid. If it keeps on going, we know that we've got an issue with these ligaments. Okay, so that's those. Let's have a look at those in a bit more detail a second. Just going to pop that one up. Here we go. So see what I mean by a bit of a mesh? Yeah. So this is your tibia. There's your calcaneus. Okay. And there'll be some arrows coming in a sec just to show you where things are. Oh, there you go. So that's your medial malleolus. So your inside ankle bone just there. And that's your tibia. So all of this mesh of connective tissue here, this is all deltoid ligament. Okay, so it's not as clear as it is on those pictures. So somebody's just asked, is there a general rule for the ligament naming in terms of which bone is said first? I've always wondered that. I wonder whether it is proximal to distal, but they're not always. So I don't know, because sometimes it's used the other way around as well, which is a bit confusing. So sometimes Americans call things one thing, and then the Brits call them something else, and the Europeans something else. So I don't think there's as long as you say the two, then it doesn't matter. I don't think. I'm not a anatomy snob like that. Okay. Oh, is it Tristan? Cool. Hi, Trist. Yeah. Sorry, mate. I can't see your picture come up. Good morning, mate. I hope you're well. Okay, so let's have a look at this. So these are your deltoid ligaments here. So there's your talus, calcaneus down there. I mean, look how smooth that talus is. It just looks amazing as it's kind of gliding through. So all of that there, deltoid ligaments. Okay, so you now hopefully, well, there you go. You can see where they all attach. Let me just go back a bit. So if you have an injury to these, you can see that if you open up that inside ankle joint, how it would just keep going. Yeah, because those ligaments are trying to keep that inside of the ankle solid. Okay, so then you can just glide with that talus. So if they're disrupted in any way, then you're in trouble. Now, you are much more likely to injure the outside ligaments than you are the inside ones. And one of the main reasons is because of this bone. Okay, so you can see how that bone there drops down quite low. So if I try to bring the calcaneus outwards, so everting it, it will hit, and the talus will hit into that bone. So it can't go very far because of that bone in the way. Whereas if I invert, can you see how much more movement is that way? Because there's nothing to stop it on this side. Yeah. So, but the very anatomy makes you more susceptible for lateral ankle sprains because there is nothing blocking the ankle on going inwards. Okay, but there is something blocking it going outwards. So that's why usually you will injure the outside ankle ligaments rather than the inside ones. So there's your talus again. It looks nice and smooth. So we've got all these different points here. There we go. I'm just going to pause that there a second, just so we can take this in. So there's your medial malleolus. So this is where all of the deltoid ligaments attach. You've got the attachment on the talus. You've got one on the calcaneus, and this specific part is called the sustentaculum tali, and we looked at that last week. So that's the shelf on the calcaneus. Then you've got the talus bone at the front. Okay, so like a posterior talus attachment, and then an anterior one. And then there is the navicular, which is that bone just there. Okay, and there's a little lump on that bone. You can feel that on yourself. So we'll have a look at that when we come to the muscles as well, because that's important, because that little lump attaches to an important muscle. So so that's that's all of the attachments for the deltoid. Okay, those deltoid ligaments. Just going to let that play through. So this is the outside ankle bone this time. There's your calcaneus. And the only other ligament that we haven't seen is this bad boy. And that one there is called your CFL. So it's your calcaneofibular ligament. So it can't be proximal to distal with that one because it's the other way around. So who knows? Okay, so this is your CFL. And there it is there. Okay, and interestingly, so what they just did there, if I just push that back. So as you go into dorsiflexion, so the toes come up towards the shin, watch what happens to the ligament. See how it goes really tight? Yeah, so usually this ligament is injured if you step on a curb and then roll your ankle, because the ligament is already stressed, and then you invert the ankle so it can open it up even more. Okay, so again, mechanism of injury, usually the CFL, the calcaneofibular ligament, is dorsiflexion with inversion. Okay, and it's usually stepping on a curb, or If you're playing sports, then it's stepping on someone's boot. Okay, so if they step on a shoe or a boot, so it dorsiflexes their ankle and then they roll their ankle. That is a common way to injure your CFL. Cool. So that is those ones. Let's have a look what we've got next. Okay. Oh yeah. So this one, this is the spring ligament, and kind of does exactly what it says on the tin. I'll just move me there. So we had a look at this briefly last week. This is the inside of the ankle again. All right. So these are all your deltoid ligaments. They're the ones we've just had a look at, and then just underneath that's that shelf bit, the sustentaculum tali, and then this bit down here, that's your navicular, and there is a ligament that joins the two. Okay, so if you have a look here, so it supports the head of the talus. So the talus sits here, and that provides like a hammock underneath the talus for it to sit into. It also supports your medial arch, so the inside part of the foot. So all in here. Has some part in the talocalcanavicular joint, so the TCN, which is what we had a look at before. So that's your talocalcaneonavicular. So that like little triad of bones there and the joints in there, this ligament kind of holds them all together. Okay, it's called the spring ligament because when you flatten your foot and you go into pronation, it helps. So obviously you'll stretch that ligament, and then you'll use up that toe region, so that elasticity, and then as you come into supinate, it will spring back and it will lift the arch of the foot, and it will help with that creating the arch. Okay, so this area here is important in the gait cycle. Okay, so it goes from the sustentaculum tali, so that's that shelf bit on the calcaneus, and then onto the navicular tubercle, which is a bumpy bit on the navicular. Okay, and that's what a tubercle is. So let's have a look at that. Just get the right one. Here we go. Get rid of that one. Okay, so this is your calcaneus, just here, and this is your navicular. So your talus would normally sit in here. Okay, so that, and we looked at that last week. So let's have a look at this. So you can see all those really nice smooth joint surfaces. That's calcaneus. That's calcaneus as well. There's your navicular. That's the shelf bit, so the sustentaculum tali. And then this bit here, that bit of gristle, that is your spring ligament. Okay, so it joins from there, sustentaculum tali, onto the navicular, and it kind of, and like I say, it kind of forms a hammock underneath where the talus goes. So the talus slots in the top onto there. Cool. So hopefully that makes sense. Why are they as a group referred to as deltoid? I tell you what, let's get Al on that because I don't know off the top of my head. I can't remember. So Al Cunningham is our person in Dictionary Corner. Yeah, off you go, Al. Let's see if you can find that one out for us. Thanks, mate. Cool. So yeah, this is an important one, right? So if you deal a lot with footballers, this is a really common injury in football. So this bit here, we've got a couple of things. So we've got this, which is the interosseous membrane. And so we looked at that last week. So that's in between your tibia and fibula. And this is tougher than bone. So the bone will break before this does. It's a really, really tough connective tissue. And it divides basically the front of your leg to the back of the leg. Okay, so that if you, I think I mentioned it last week, you can have an injury where you have a bleed into the compartments, and you have something called compartment syndrome. And the reason why it's a problem is because if you're bleeding into that space, there's nowhere for the blood to go because of this really, really tough connective tissue. And then it can start compressing nerves and causing all sorts of problems. And it's a medical emergency, so you need to get to the hospital straight away. So that's one of the reasons why it's a problem, is because of that membrane just there. What we want to look at though is this just here. So there's your fibula. There's your tibia, and then there's this band of connective tissue across the two. So this is what's called the syndesmosis, or the tibiofibular ligament, because it goes from the tibia to the fibula. So it goes on the front just here. Okay, now I'm just going to switch back to my main screen just so you can see this. So this is why it's a problem in football, because you wear studs, okay, or any sport where you have a rapid change of direction and the surface and the shoes are really grippy, okay. So quite often things like netball, basketball, those kind of things, you'll get these kind of sprains. So the foot lands, okay, and you've got studs. So the studs are now in the ground, and then you want to change direction, but the studs stay still. And what happens is it opens up. So if you imagine there, and then a twist, and then if you have a look at what happens in the talus, it just opens up that talus joint. Okay, so that then injures that ligament just there, and it kind of pops the two bones apart. Okay, obviously you can get various degrees of the injury, but if the foot lands still and then you twist, it just opens them up, and then that will injure those syndesmosis ligaments. So let's have a look at those. I think I've got them on here. Yeah, I'll just pop that one there. Here we go. So this is the interosseous membrane, which we had a look at last week as well. So there's your fibula, tibia, lateral malleolus, medial malleolus, just so you're orientated, you know where things are. So there's the interosseous membrane. So this is the bit that's in between the bones. Forgot to put that on there. It's quite handy. And then we're interested in these joints. So not the proximal one at the moment. We'll do that when we get to the knee, but this distal one. So this is your tibiofibular joint. And can you see that little bit of movement there? So this is the tibiofibular ligament. So if you twist that talus, then it will just pull apart these bones. And there's one at the back as well, posterior tibiofibular ligament as well. So that's a high ankle sprain or a syndesmosis injury. Okay, so that's what that one is. Cool. Right. Okay, so now we're going to have a look at a couple of the ligaments on the sole of the foot. So this is the plantar aspect of the foot, and that's why they are called plantar ligaments. And we're also going to have a look at the plantar fascia. Okay, so you might have heard of that before as well. So this is really quite impressive bit of engineering, whoever designed us. So we've got the long plantar ligament. Let's see if I've got the short one on there as well. No, and there is a short one as well. So I'll show you both. I haven't got a picture on here. So let me show you those. So these plantar ligaments are really deep. There we go. Okay, so there's your heel bone, just there. All of the skin has been taken off the foot, and we're pretty much down to the bone. And that ligament there, that's your long plantar ligament. So let's have a look at this. So that one just there. So what we've got is a bit of protection for the undersurface of the foot, but it also helps with the maintaining the arch in that back part of the foot as well. And this is really cool. So that bit there that he's just about to grab hold of, that is the tendon of the peroneus longus muscle. And there's your long plantar ligament. And the long plantar ligament goes over the top of the peroneus longus. Okay, and we'll get to that when we do the muscles. But look at that. How cool is that? Okay, what a good design. So that ligament there will help protect that muscle, all right, as it passes through. So probably worth just having a look at that again, because that is pretty cool. So you've got third, fourth, and fifth bases of the metatarsals onto the calcaneus, and then underneath that ligament is where your peroneus longus will go. Okay, and again, we'll cover that when we get to the muscles. So that's your long plantar ligament. And then we've got a short one as well. Let me just show you this one. Just bring that up. Here we go. So this is deep to the long. Okay, so they've taken the long off. So there's the short one. And this doesn't go as far as the metatarsals, it goes to the cuboid. Okay, so it provides support on the outside of the arch and again help maintain the structure of the foot. Thanks, Al. If you can't find it, mate, don't worry. I'll have a look afterwards. And then there's the groove for the peroneus longus. So the peroneus longus will come under here, across there, and then the long plantar ligament covers it. Okay, so the short plantar ligament comes up to the cuboid, and then the peroneus longus comes underneath, comes just in front of that. Okay, so it's all really, really intricately designed, and everything kind of has its place. And then there's another layer, and that protects another bit. It's absolutely fascinating. And the bit that you've probably heard of before is, let me just show you this one. There it is. I was thinking, oh no, it's not there. Here we go. So this is your plantar fascia. So that's your Achilles, calcaneus, so heel bone, and then it's continuous with the plantar fascia underneath, and then that attaches into the heads of the metatarsals. Okay, so let's have a look at this. Thanks, Dan. Okay, here we go. Which makes sense. I knew it must have something to do with the shape. So it's named after the Greek letter delta, which is shaped like an equilateral triangle. Yeah, so that's why it's deltoid ligaments. That's why it's deltoid muscle, because it's the same kind of shape, but inverted deltoid there. Yeah, cool. Thanks, Dan. Thank you very much. So plantar fascia, just there. And let's have a look at this. So when you bend the toes up, there we go. So when you bend the toes up here, so when you're walking and you put your foot on the floor and then your toes come up as you push off, you stretch the plantar fascia and it creates loads of tension in the undersurface of the foot and it makes the foot rigid. So that when you push off on that big toe, you have a rigid lever to push off on. So if this system doesn't work, and this is called the windlass mechanism, so when the big toe comes up, it stretches all the fascia underneath. If that doesn't work very well, and you have a floppy foot when you push off, you tend to then push off on the inside of your big toe, and you get a bunion. Okay, and you get a bit of a what we call a valgus position of the big toe, hallux valgus. So what should happen is you should step down. Okay, your foot should flatten. As you then go to toe off, so this big toe starts to extend, it pulls on all that fascia, creates your arch in your foot, makes your foot solid, and then you push off. Okay, so this bit of fascia has a big role to play in our gait cycle. So let's have and all those other ligaments are underneath that supporting it as well. So that windlass mechanism, as the toes are brought into extension, then it straightens all that fascia there. So let's just have a look at that again. Okay, so a little bit of give, but then when you bend the toes, solid. Okay, and that's what we want. We want a solid foot to push off on. Otherwise, it can cause problems with the joints in the foot. Okay, so that's what the windlass mechanism is. So when the big toe comes up, stretches the fascia, plantar fascia, tightens everything, solid foot, and then you can propel yourself. Okay, so that is all has to happen at the same time. Cool. So that is that one. Let's just see if I think I've just left one thing out. A couple of things out. Yeah, two more things to cover, and then we're done. Okay. So I know this is a bit of a long session because there's a lot in the foot. Okay. So let's have a look at this one. This is really cool, and this is really important as well. So we've got these bands of thickened fascia around the leg, which help to keep tendons in place. Because if they weren't there, when your muscles contract, they'll still be able to generate force, but because there's a pulley system and it's kind of going around a corner, you're able to generate a lot more force with a much smaller muscle. And this is really important with the foot and the ankle, because obviously walking, running, we want maximum efficiency. So we've got this superior extensor retinaculum. Okay, and if you've not heard that word before, we'll have a look at it now, and you'll hopefully won't forget it. And then this is the inferior extensor retinaculum, and there's one at the back as well, which is a flexor retinaculum. So let's have a look at those, and then hopefully it will make a bit more sense. Where are we? There. Just get rid of that one. Here we go. Okay, so this is the front of your leg. There's your fibula, and that flappy bit there, that's a bit of retinaculum, and so's that flappy bit there. Okay, so let's have a look at this. So your tendons go underneath these connective tissue tunnels. Okay, and these are just thickened bits. Okay, so the tendons run underneath those and go down into the foot. There you go. Okay, so that's what it looks like normally. So the retinaculum goes around the whole leg, but these bits are just the thick bits. Okay, so these bits are the bits that are toughened, and they've developed that way because of the pull of the muscles. Then we've got these on the side, so the perineal muscles go through those, and some of the blood vessels as well. And then we've got another one on this side as well. So this is the flexor retinaculum. And again, there are tubes coming through this where the tendons go and the blood supply goes. So this is the tunnel for the flexors. So when we come to have a look at the muscles, your muscles go through those tunnels to all the various bits of the foot. So when we come to bring in the muscles, we'll have a look at them in compartments. Okay, so the ones at the front, the ones on the side, the ones at the back, and the ones on the inside. And then they go through those tunnels, they go through those retinacula. And then the only other thing to have a look at is, where is it on here? Here we go, this one. Now, you might have seen joint capsules in a book, and it's kind of got a bone and then a big bobble around it, and it all looks nice and neat, and then synovial membrane on the inside. They don't look like that in real life. This is what they look like. So this is a capsule around your foot, so around that talocrural joint here, and this is it. Okay, so it's a bit tighter at the front, a bit looser at the back, and it's because it needs to be loose to allow movement. Okay, so as you move and as you glide, you then stimulate synovial fluid production on the inside of that joint, and that's what a joint capsule looks like. Well, that's what the one looks like in the foot anyway. And I think, let me just make sure I've covered everything. Yeah, that is it. Okay, so this is a bit of an introduction into next week. So if you want to read ahead a little bit and kind of prep some stuff, then we're going to be looking at these compartments of the leg. Okay, so we've got a compartment at the front, so this red zone, and we'll go through each of these and what they are. Then you've got a compartment on the side, a deep compartment, and then a superficial one just here. Okay, and they each contain specific muscles, and they are all separated by these lines. Hopefully get along that line there. So that these are lines of connective tissue. So we'll have a look at those again next week. And they separate each of the compartments out. So the one that we've already seen, so remember this is a top-down view. So there's your tibia, there's your fibula, and that join in between, that's your interosseous membrane. So that's the one we've seen already. So you can see it divides this front section to this deep posterior section here. Okay, so if there's an injury to this deep posterior section and it bleeds, it's just going to bleed into that space, and then it's got nowhere to go. Okay, so that's why compartment syndrome is such a problem. So yeah, that's what we're going to be covering next week. So if you want to do a little bit of revision about the compartments of the lower limb, and we won't be able to cover them all in one session because there's loads of stuff to do. So we'll probably just do the front and maybe the deep posterior compartment, and then build on that, build out. Okay, cool. So hopefully that was useful. Tried to bring in a little bit of clinical stuff as well, and all the stuff we've been talking about with the ligaments. The reason why we talk about it, I mean, it's okay knowing that, you know, that goes from there to there. But what's its role? What does a ligament actually do? So then once you understand that, then and you understand the anatomy, you can then make a better informed decision about what's going on with someone if they present with a certain condition or injury. So yeah, hopefully you found that useful. You always seem to prefer the right side. Is it this side of the screen, you mean? I think it's just because if I go that way too much, then my green screen doesn't cover it. That's all. That's all. There's no real reason. No problem. Thanks, Al. Thanks for your help, Dan, as well, finding out about the delta. Yeah, so the delta sign, obviously, that makes sense, doesn't it? Delta and deltoid, with the ligaments going across. Noel, I hope that was, I hope you did, well, maybe put your baby to sleep. You never know. Just play me whenever baby's just a bit fidgety, and then maybe I send them off to sleep. Cool. So have a good week, guys. And I'll see you next Monday, and we'll start layering on the muscles and the tendons. Cool. See you then.